Hello everyone, and welcome to today's presentation. I'm excited to share some insights on ulcerative colitis. The title of our talk is simply Ulcerative Colitis, and along the way, we'll explore what this condition is, clarify that it's an inflammatory condition rather than an autoimmune disorder, and discuss some key facts. So, let's get started and delve into understanding this important topic together. Now, let's look at pseudopolyps, which are a common feature in ulcerative colitis. These are essentially areas of inflamed mucosa that have become raised due to healing or regeneration, giving the appearance of polyps, but they are not true neoplastic growths. One key point is that pseudopolyps involve partial thickness of the bowel wall and tend to be spread throughout the colon, often seen in cases of pancolitis, where the entire colon is affected. The most common site for these pseudopolyps is the rectum, which is often the starting point of ulcerative colitis and a site we pay close attention to during diagnosis and management. Moving on to clinical features, patients typically present with frequent bloody diarrhea, often 10 to 15 times per day, which can be quite debilitating. This blood loss can lead to anemia, making patients feel tired and weak. Another important aspect is protein-losing enteropathy, where inflammation causes proteins like albumin to leak out, leading to decreased serum albumin levels. This often results in swelling around the eyes, what we call puffy eyes, due to fluid retention. In severe cases, we might encounter toxic megacolon, which is a dangerous complication characterized by colon dilation greater than 6 centimeters. This condition is more common in ulcerative colitis than in Crohn's disease and requires prompt intervention. Lastly, it's worth noting that the risk of developing malignancy in ulcerative colitis is comparable to that seen in Crohn's disease, emphasizing the importance of regular surveillance in these patients to catch any neoplastic changes early. Let's delve into the investigation aspects now. PNCA, or paranuclear antineutrophil cytoplasmic antibodies, are also present in conditions like primary sclerosing cholangitis and microscopic polyangiitis. This makes PNCA a helpful marker when we're trying to differentiate between these diseases. The investigation of choice in suspected inflammatory bowel disease, particularly ulcerative colitis, is colonoscopy. During the procedure, we often see signs of proctitis, which is inflammation of the rectum. A biopsy taken during colonoscopy typically does not show granulomas, which helps distinguish it from Crohn's disease. In addition to colonoscopy, imaging studies like CT enterography are valuable, especially for assessing the small intestine and detecting complications. Barium enema remains a traditional diagnostic tool, with the earliest feature being a granular appearance of the colon due to pseudopolyps. Furthermore, as the disease progresses, we observe a loss of haustrations, the small pouches in the colon, leading to what's called a pipestem colon appearance. This classic feature indicates long-standing disease and helps us understand the extent of mucosal damage. Connecting these points, each investigation provides unique insights, helping us confirm the diagnosis and assess disease severity. All of this fits into the bigger picture of managing inflammatory bowel diseases effectively. Let's talk about the treatment options for ulcerative colitis. The drug of choice here is sulfasalazine, which is often used to manage the inflammation and keep the disease in remission. When a patient experiences an exacerbation, steroids like budesonide enema are typically employed to reduce inflammation quickly and effectively. In cases where the disease progresses despite these treatments, infliximab infusion can be considered. This is a biologic therapy that targets specific immune system pathways involved in the inflammation process. Now, moving on to surgical indications, surgery becomes necessary in certain severe situations. One key indication is toxic megacolon, which is a life-threatening complication characterized by rapid colonic dilation and systemic toxicity. Another indication is when the rectal mucosa becomes friable and bleeds easily upon touch, indicating severe mucosal damage. When surgery is indicated, The preferred procedure is procticolectomy combined with ileal pouch anal anastomosis, or IPAA. This approach removes the diseased colon and rectum and creates a pouch from the small intestine that's connected to the anus, helping preserve continence and improve quality of life. Overall, understanding these treatment pathways and surgical indications is crucial for managing ulcerative colitis effectively and preventing serious complications.